So this portion of the endocrine lecture specifically relates to diabetes in children. So as a brief refresher, diabetes, most of you should have been exposed to that already and will continue to get more exposure through your GMP classes. So for this portion, I'm really just looking at diabetes in relation to children. It is the most common metabolic disease we see in children, and we do see it peak in that school age, late school age, early adolescent age brackets. It is a disease of hyperglycemia that results from the defects in insulin secretion, insulin action, or both. So any of those mechanisms can cause diabetes to result. So in terms of type 1 diabetes, this results from the destruction of the pancreatic beta cells that do not secrete insulin. So the body is really dependent upon exogenous insulin sources. It is an autoimmune disease, and while it does have familial tendencies, there is no specific pattern that we note. In other words, we don't know that if mom has it, the children will all get it, it skips a generation, et cetera, et cetera. We don't really know that pattern. How it manifests itself is very similar to how we see it in the adult population. We may see polyuria or polydipsia. They may have enuresis, even though they may have been previously potty trained. They may have excessive hunger. We may note weight loss, ketoacidosis, and an initial period of decreased insulin requirements. But then thereafter, that initial period, they do require insulin for survival. So in type 1 diabetes treatment, it's just like it is for the adult population. However, it can be a little bit more difficult or dicier doing it in children because children do have erratic eating behaviors, children do have different activity levels, and it can be tough to recognize hypoglycemic signs and symptoms in children. So we do give insulin therapy. Most children get multiple injections per day. They get them with meals and at bedtime. So again, that can be a difficult part of this when working with children and getting needles every day. We are using insulin pumps a lot more successfully with children, and I think that will continue to be the direction we will head in because insulin pumps do keep our glucose levels at very tight standards, which we do know does have long-term benefits. So, of course, as a child, if they're being diagnosed earlier, their risk of long-term complications from diabetes is much greater than if diagnosed much later in life. So the closer we can keep this glucose control, the less likely they are to develop those long-term complications. We will see, in terms of long-term complications, cardiovascular complications, renal complications, and again, those will be decreased if we do tighter blood glucose control, and thus the pumps are much better for that. However, if we aren't using those pumps, frequent insulin injections are common. We also need to work on nutrition therapy with these kids, calorie counting. Usually in the beginning, we have dietitians working very closely and endocrine specialists, advanced practice nurses that specialize really in the care of children with diabetes. As children get older and we get into that school age bracket, we want them to be involved in carb counting and insulin administration. When they are in that preschool and toddler zone, then we will have them helping us with selections of foods and snacks. Exercise program is the third part of treatment that is incredibly important, but we need to remember that children need to have an adequate calorie intake in order to prevent hypoglycemia. Regular exercise and fitness is good, but we need to remember that any young adult that is involved or adolescent that is involved in extreme exercise or involvement in team sports that involve a lot of practices and practice time and exertion do need to have very close management, and we may need to have specialists involved to ensure that they are kept safe. DKA is that life-threatening complication that occurs when glucose is unavailable for metabolism, and so our body begins to break down other sources, and ketones are released as a result of that. So we can get ketonuria, which is eliminated in the urine, and acetone breath, which is eliminated by the lungs. It is a severe metabolic and electrolyte complications that result from this and can lead to coma and death if we don't deal with it. Usually are often caused by missed insulin doses or incorrect insulin doses, or when the patient is involved in some sort of traumatic event or injury. It is seen with polyuria, polydipsia, of course, those ketones, that fruity smelled breath and ketones in the urine. We may see pain, nausea, vomiting, flushed ears and cheeks. Blood glucose levels will be greater than 250 and ketones will be present that will cause the urine to be acidotic, and the blood to be, acidotic. Treatment should be instituted in the intensive care unit. These kids need immediate treatment to prevent that long-term complication. Hypoglycemia in children can develop within minutes, and so we need to be keenly aware of the signs and symptoms of that and monitor children for hypoglycemia. This occurs when blood levels drop below 70 and often is noted when children are going through growth spurts, or with children who have unpredictable eating habits and all this crazy physical activity, which we do note in our school age and adolescent populations. They tend to be eating more with friends, tend to be involved in a lot more activities and exercise. Most often these episodes can occur at night and can be very severe and can lead to seizures. Our treatment is the immediate administration of glucose sources. Type 2 diabetes is something that we're seeing more and more in young children, and especially in areas where all of us are working currently or doing our community homes. Type 2 diabetes is associated with obesity. And of course, we know there is an obesity epidemic in this country. It is the insulin resistance or the alteration of insulin receptors in the body. Excess body fat will decrease the body's ability to use insulin. And with the onset of puberty and the increased secretions of growth hormones, that also can contribute to the development of insulin resistance. So you can see that age bracket where we're seeing more growth hormone releases and the onset of puberty, late school age, and adolescence. These are children who are at greater risk. And if you add into it the presence of obesity, we can certainly understand how we may have more complications and more numbers of children developing type 2 diabetes. So you can see the risk factors there: obesity, decreased physical activity, low socioeconomic status, diet, and again, as I said, this is a great concern today for health. How does it present? Symptoms will vary. Some kids will be asymptomatic, or they will have some of those common signs and symptoms of polydipsia, polyuria, fatigue. They do have this acanthosis nigricans, which is a hyperpigmentation and a thickening of skin, noted on the back of the axilla and the skin surfaces, flexor skin surfaces. So we can see some of that, and that is a risk factor if noted for the development of type 2 diabetes. And children who are obese and may have a high waist circumference is often a presentation for type 2 diabetes. Our treatment involves normalizing blood glucose levels, and initially we may need to give these kids some insulin for a short period of time to get them back on a healthy, normal blood glucose level. We will then work with them for weight loss efforts, exercise involvement, diet modifications, and they may need to use oral metformin if exercise and diet control are not enough. But we really try to do it without medication if at all possible. When we're working and teaching children and families about diabetes, it's really important that we get the experts and people that are very knowledgeable about diabetes. So diabetes educators, advanced practice nurses are often involved in this. Education needs to include a couple things. First and foremost, children when diagnosed will go through a honeymoon phase, meaning that after they are newly diagnosed, they will go through a period where they may have some residual beta cells that will function, and therefore they'll have a decreased need for exogenous insulin. This is just a phase, why we call it the honeymoon phase. It doesn't mean the child is getting better, and parents need to be reminded of that and note that they may see it, but it doesn't mean the child is improving. We need to go over insulin treatment, goals, how to administer it, and the frequency at which we need to administer it, and the need to keep that glucose level management tight. We need to talk about sick day protocols, just like we do with the adult population. And we need to discuss with them diets, carb counting, regular exercise, reading food labels for carbs, such that they become very knowledgeable about how to manage diet. In working with the child with diabetes, it is really important that we take their developmental level into play. So when we talk about preschoolers, they are at a stage of developing autonomy, and so we want them to have the opportunity to develop that within the confines of a disease process that really takes a lot of control away from them. So we want them to be able to choose snacks and maybe choose the finger that I will use in order to do their glucose testing. For school-age children, we need to begin to start to help them develop some responsibility for the care of their illness. This is something that will really enhance their growth and development, so they can begin to test their own blood for glucose, and they can begin to administer their own insulin. Let them select food and snacks. Let them begin to count carbs and have them begin to recognize in themselves those signs of hyper and hypoglycemia. We follow a child in one of the schools in Philadelphia through my community home rotation. And this little guy is now 7 years old and is administering his own insulin and is doing a lot of his own carb counting with the help of the school nurse. So they are very capable of doing that and beginning to manage that. In the adolescent population, we may see a little bit of rebellion in terms of having to follow these diabetic regimes, which can have an impact on their socialization and their ability to appear quote unquote normal and alike in terms of their friends and peers. So it is important that we need to follow up on that and follow them closely because it will affect their ability to manage their glucose closely. It will be important for us to make sure that they are managing as well their self-care, their carb counting, their insulin needs and administrations, and recognizing the signs of hyper and hypoglycemia. And finally, we do need to talk about drug and alcohol use and its interaction with diabetes. It's important that these young adults who are at the age bracket where they may try some of those behaviors understand the impact it may have on their glucose levels. And finally, we need to make sure everyone knows, no matter what the age is, we need some sort of medical alert bracelet such that if any time an emergency occurs, emergency responders will know and identify the child as a diabetic.